Physical therapy is always known due to the osteomuscular topics and issues. Throughout the years, it has changed. The approach of physical therapy has changed. We've seen the great weight of patients for the respiratory problems. The scientific evidence, as Dr. Ancoichea said, has shown us that if we do work with the respiratory patient on his quality of life is improving very much, although the spirometric value doesn't improve, the patient tells that he improves significantly his quality of life when he does training to effort training and physical therapy exercises for his breathing. How do we focus the treatment of the patient? What can we give the respiratory patients within this whole set of these different experts? We work on three main aspects. The first one, we collaborate as the rest within therapeutic education. We help the patient to understand what happens to him, why he feels breathlessness, what is breathlessness, what is happening in his lungs, and why can't he lead a normal life. But why is he the snake when he does the activities he did before? We try to explain how this affects his musculature, what is happening at the osteomuscular level, what happens and why does he has muscle cramps and why are his muscles hurting when he does the activities he did before. We reinforce and we make him understand the importance of nutrition. This muscle has to be very well fed so that when we start making it exercise, it improves its effectiveness and it is able to make exercise with less cardiac output and oxygen output. And we teach him to live together with this dyspnea, with this breathlessness, and understand when he feels that sensation. Not always do we have to stop. Sometimes we have to do things slowly and organize yourself differently. And this is something that we do on a daily basis when they are under our treatment. Try to give them positive experiences because we only learn through experience, and what they do feel and they do experience when they work and do physical exercise. Although they feel some breathlessness, they have to be able to understand that they see that they can go on biking on the static bike, although they feel that, and this allows them to keep on working and adhere to what is so effective as is physical exercise. All this is done throughout all sessions that we have to do with them, with the workshops. This is a very important part, as Patricia said, to speak with the patient and to explain to him and make him feel things so that he may understand them and then internalize them and live them. And then we do something else. We work on another field, respiratory physical exercises, where we show him clearly how he has to inhale air, how he has to expire the air, so that work on the respiration so that it is more effective, so that he's less tired, less times per minute, in order to improve the elimination of secretions. We teach him to not be in anxiety and anguish and be relaxed through respiratory techniques. And then we work on the last aspect, that is the fundamental pillar, physical exercise, physical activity. As we study the COPD, we discover that it's having more, the fact that the patient moves has the greatest weight. Having a similar spirometry, one similar to another patient, the one who is in movement, the one who goes out, the one who does things, has a better quality of life and better prognosis than the one who is sitting in his chair at home. And this is a fact that is undisputable. So when Esther has mentioned, well, you tell me it's good. Yes, you tell me it's good. You have lived that, yes. Then, of course, we have to move. And we do show them, we start them moving, as I'm going to do now. I'm going to make you move. When you are in contact with a physical therapist, that is, he puts you to work. No, it's not only to listen to him. How do we work with them? What's the first thing we do when we start training the patient? The first thing that he does when he comes with us in the room, we teach them this, the importance that hand hygiene has, or any other technique of cleaning in order to prevent contagion. We teach them good hand hygiene and measures to prevent contagion. We also teach him how they have to take their medications always before exercise. The issue of oxygen, they removed it to do the bike exercise at home. They only put the exercise when they were watching TV. Teaching them the proper use of oxygen therapy, or always work in coordinated fashion with nursing and pneumology departments to try to organize their daily activities around this breathlessness, but without living it with anxiety and anguish. You have to learn how to breathe whilst you are taking a shower. You have to learn how to breathe whilst you are cooking. But this doesn't mean that you can't do it. You have to do it in a specific manner. And this is taught in the daily practice. We do from workshops that, as the one we will have in the Respira classroom today, to the training groups for effort training that we do for 2 months until respiratory physical exercise in a group in the 9th plant of this hospital. We do a lot of education. We believe it's a fundamental pillar for the patient. The patient has to know what is happening to him. He has to understand it, because this is what is going to allow him to adhere to the really efficacious treatments. And then the second part, where we teach how he has to inhale air. He has to use his nose, his mouth, the transverse muscle of the abdomen, and mainly this one, the head, his mind. He has to be calm and comforted. He has to control and do voluntarily the use of his mind in order to prevent that cycle of anxiety. I can't go on. I have to phone the emergency department. We have to breathe. We have to stop, but we have to breathe slowly, not rapidly. And we are going to do that every day. In patients, when they come from their home, we teach them where they have the diaphragm, what we have to do with the diaphragm, how they have to take the air very slowly through their nose, how they have to maintain it inside, to do hyperventilation where the air is not maintained inside. We have to, here you can see pictures. It says 2007. We have pictures from 2005. We have been working with the patients for a long time. You practically know them all. So once we teach them how they should take that air, we are going to teach them as well to expel the air, and to blow out the air, because they have problems to inhale the air. They can't put air in their lungs. But what is really the problem? The problem is that they don't let the air coming out. They don't expel the air properly. So we practice very simple exercises where they see that during a long time, much longer time than what it takes to fill the lung, they have to be expelling the air. The first time we give them a straw to blow in a glass, and now take air and keep it inside, and very slowly make small bubbles during as long time as you can. And we show how long time they do that. What happens? They are much more time than what they have been inhaling the air, because they have a lot of air inside that is not efficient, that is useless, and we teach them how to eliminate that air, doing something as simple as this. And we teach them to do a slow expiration that is deep, eliminating the hyperinsufflation, this air that is inside the lung that is useless, that doesn't allow the lung to be filled efficiently. And then the secretions have to be expelled outwards, and this slow inspiration with the glottis open without causing a cough, because coughing is only efficient when it's over the upper part of the sternum. The mucus that is inside, that doesn't come out when you cough, but it does so when you have the glottis open. And all those things are learned, and once they learn them, they use them in any place. We teach them the positions where it's easiest for them to work for the diaphragm, in which the dyspnea seems to be more difficult, or when the dyspnea appeared because they have been going up a hill or an aggressive activity, they can place themselves in such a way that it's easy to recover their breathing, fixing their arms. All those things, we work on them throughout the sessions so that they can have always an experience of what we want them to learn. They have to practice, they have to do it in order to really be able to do it in their daily life. The other day, in the group that we are working on now with Enrique and Patricia was with them the other day, one of them had breathlessness crisis. And I don't know if you were there as well. And I was about to phone the emergency department because I already had the feeling of loss of consciousness. And Teresa, I don't know where the voice of Teresa came from, but breathe, breathe, be calm. It was not a miracle. This is how you re-educate or retrain something. You repeat and repeat and repeat, and then it's recorded as such an automatism. And this is something that she knows how to use when she needs it. This is what our work is all about: to repeating and repeating, and at the end we are able to reach the goal. And the most difficult part for them, they get they gasp for air, and they still have to do exercise nevertheless. And they always say the same: when you are there, when Mrs. Rottenmeier is with us near your bike, you can put up a little roar, more rapid, or I can put more resistance to the bike. Just 5 more minutes. I have to do that, but when I go home, nobody's forcing me, then it's much more difficult to do that, to be able to keep on doing exercise. How can we able to achieve that? Through this experience. They have seen that they can do that. They have entered with this breathless situation of 3 or 4 in the Voss scale, and when they go down from the bike, they have a feeling of 2. They have less sensation of breathlessness after having been on the bike, and they have to live that. They have to feel that, because that's when they will go up on the bike day after day. And this is what we try to do with them: help them and sharing with them that experience. And they do share them among them, and they have a nice time together. They are a group, they strengthen each other. Then they have, let's go, try to go to that gym. They socialize with people that are as they are, that gets tired when they walk, as they also get tired, and this is very important. And well, here you can see pictures of how the training sessions are. This is a picture of a program that we started in the hospital. Early physical activity onset in admitted patients. As soon as they were admitted, their respiratory function was better. They received all the therapeutic package, but they stopped moving. So they worsened their capacity of doing aerobic exercise. So when we saw that making a little physical activity during their admission, they didn't lose that gait training, etc., we started working on that aspect as well. Here we can see a different type of patients doing all these activities that we put them to do. Well, something as simple as this band, this rubber band, that can give a very important physical activity, especially for the upper limb. This is a fundamental part of the chest that is going to allow us to open and make flexible all the ribs, expand the chest, that is the one that is pulling from that lung. And how can we make them work? We ask something as simple as this. They have to pull from a rubber band, but always in a special manner, breathing as we have indicated them to do. They have to work on all type of muscles. We work very much on the upper limb, and now some exercises for the lower limb. But we will always ask them to breathe in a controlled manner. They always have to take in air at the moment where we are at rest. They have to maintain the air inside. The moment of apnea is very important. And then always when they do the effort, they have to blow out the air so that the fatigue and the breathlessness don't appear. And we have different exercises, 10, 20 repetitions. Always focus on the needs of the patient. The patient gets gasp for air when he's having a shower. We work more on the triceps or more on the muscle elevator muscles of the arm. The one that is patient that has to cook and has to take things from under the table, we have to make them do other things. Something as simple as making this gesture, squatting, yes. It looks like when I blow out the air, it allows us doing X repetitions a day to improve very much the capacity of the patient to do physical exercise. And we tell the patient he has to do aerobic exercise. Aerobic exercise with a rubber band, in a belt, in a treadmill, the static bike, or just we can see this the picture of the patient Argimiro. I showed it to my mother. This patient is 91 years old and he keeps on biking. Pedalier is very easy to have at home. It's a useful tool that has shown its efficacy with patients with diabetes and any other characteristics. This is something as simple as having it hidden under the table whilst he is looking at watching TV. He can be pedaling there with this pedalier, this machine, and be there for half an hour, three-quarters of an hour, 10 minutes in the morning, 10 minutes in the afternoon, what he can. Don't tell me this is difficult. Anyone can do that, and has to be proven. They have to experience that in order to then do it. And when they have experienced that, as Archimedo, they don't stop doing it. In fact, I think they become addict to exercise. And there are some that always do that. They never stop doing it. Apart from training them and teaching, we will have to be able to make the next step. That experience has then to be transferred to the activities that make them happy, that fill their life with happiness, that gives them gratifying experiences, exercises or activities of their daily life, from going out with the dog until being with your friends to play cards or whatever, or go to play with your grandchildren. But what is efficient is to increase the amount of physical activity they do in their daily life. The greater amount of physical activity hours, the better prognosis for the patient. But they are also happier, or aren't they?
It's not about filling up the day or filling up the hours, but it's about living. And as we were saying, breathing control at all times to make sure there is no shortness of breath, and if it happens, keep control over it, and remind patients that, let me remind patients that there's this website where they can check all those exercises free of charge on the internet, because we've developed them for them. That's been all. This is Archimedo's picture given by Patricia, proving that you can be 91 after 7-8 years working with me. He keeps on exercising. But it's not Archimedo's picture only. We will play a video as well, recorded by Patricia yesterday, where they talk about you. I met Archimedo when I was a resident, if I'm not mistaken, and he's 91. So, see, a COPD patient can live and make an effort every day. Video, please. Archimedo, I'm pedaling here. When do you do that, Archimedo? When do you use the bottom bracket? In the morning. Every day? Every day. How long? 15 to 20 minutes. Some strength, right? Yes. Yes. You need to tighten the screw. How long have you been using the bottom bracket? 3 years and a half or so. All right. And what's up in your hand? And breathing incentivator. Is it? When do you work on that? Early in the morning as well. Sometimes in the afternoon, but not so many days. After I'm done with the bracket? You mean, what do you mean? Oh no, when I'm done with the exercises, I work with incentivator. What exercises do you mean? Many different ones. Do you want to show that? No, just tell me. Knees. Bands for the arms. Diaphragmatic breathing. Hands up. But controlled breathing, right? Yes. Good. Same as in what I used to do with Teresa. I think she was one of the best ever. Well, that's my choice. She is a good teacher. She is. Because you keep on exercising every day at home, and that's very much important. Yes, say hello from me. How old are you, Archimedo? How old, you mean? 90. 90? And see the speed of your pedaling? Say hello to Teresa. Say hello. Teresa? Hello. You know, I'm very happy with you. See? Living with COPD, bringing life to life for our COPD patients.